Today we're discussing Chapter 23, Allergic Reactions. In this chapter we're going to break it down similar to the past chapters, dealing with primary assessment, secondary assessment, your reassessment, medications that you may be able to use, and emergency situations. So we're going to help you identify allergic reactions and the signs and symptoms that go along with that. We're going to talk a little bit about epinephrine in the self-administration that a patient may do, but also in the EMT-administered epinephrine. It's important to note that an allergic reaction is an exaggerated immune response. So the immune system is going to respond to foreign substances in or around the body, and when the body senses these allergens, it is going to have a response that causes the patient to be uncomfortable and in some cases can even lead to death. Anaphylaxis is the life-threatening allergic type of reaction. In this situation, the body's blood vessels begin to dilate. This causes a drop in blood pressure. The cells leak fluid into the interstitial space, which basically causes swelling. And because of this swelling, it can affect the airway. Now, an allergen is what is causing the body to have this allergic reaction, and everybody's a little bit different. People can have allergic reactions to just about anything. Insects, such as bee stings, wasp stings, foods, nuts, including peanuts, almonds, walnuts, eggs, milk, and shellfish. Plants, things like poison ivy, poison oak, medications, penicillin, sulfa drugs, or other substances they may come in contact with, which could be things like dust, soap, or substances that are in the air. Here are just some examples in the image shown. Please keep in mind that you can be exposed to these allergens through inhalation, through ingestion, through injection, as in a bee sting, or even topically if it gets on the surface of your skin and is absorbed. Latex is an allergy that we are usually more concerned with in the field of EMS and in medicine because many patients have latex sensitivities, and that may include us. Patients who've had multiple surgeries may have increased likelihood to have this allergy. Those individuals that wear latex gloves or handle latex on a regular basis can develop a sensitivity over time. It's important to know that an allergic reaction does not occur the first time that the individual is exposed to that allergen. On that first exposure, the immune system identifies it and starts to form those antibodies. Now, on the second exposure, those antibodies combine with the allergen, and we start to see some signs and symptoms, including a release of histamines and a whole spectrum of other symptoms that may occur. So again, remember, on the initial exposure to the allergen, the individual is not going to have that anaphylactic reaction. But with continued exposures, that reaction can continue to worsen. As we start to monitor this patient a little more closely, you may see dilatation of blood vessels, which can cause some hypotension due to the decrease of blood flow that is returning to the heart, flushing of the skin because those blood vessels are dilated, pooling the blood near the surface, development of angioedema. Angioedema is the swelling of the lips, the tongue, the soft tissue around the mouth and neck. And with this soft tissue, we can also have swelling of the vocal cords, making it difficult for the patient to breathe and speak. More signs and symptoms that you may see is the development of urticaria. This is hives on the skin or a rash that develops. Urticaria or hives usually looks like the large welt type rash. Bronchoconstriction. This decreases air movement in the lungs, and you may hear the patient wheezing when you auscultate lung sounds. Thick mucus can develop in the lungs as well, causing the patient to cough. On page 654 in your textbook, there is some images with angioedema and urticaria. What many don't understand is that the course of an allergic reaction is unpredictable. That simply means we don't know who is going to develop an anaphylactic reaction necessarily, and how long after their exposure to the allergen they're going to experience this. Severe reactions may be immediate, but they may take 30 minutes or longer to develop. Mild allergic reactions can progress rapidly, especially if the allergen remains in context with the patient. It's important to monitor any allergic reaction closely. Again, everyone is unique in what they may be allergic to or how they may react to that allergen. It's fairly common to see issues with the skin that may include itching, hives, a flushed appearance to the skin, swelling of the face, neck, hands, feet, or tongue. Sometimes patients will complain of a warm, tingly feeling on their face, their chest, or their hands and feet. This is one of the images that is in your text, but you can see the flushing, the redness of the skin. If you look close, it kind of looks speckly, and the patient here has swelling around the eyes. That's pretty noticeable. This is also an image that is in your textbook showing urticaria or hives. You can see these large raised red areas that are irregular in shape. They can scatter themselves on any particular part of the body, or they can be covering the entire surface of the skin. Patients may have difficulty breathing. They may feel tightness in their throat or their chest. You may hear them coughing due to that increase of mucus. You may hear their wheezing. It may be audible even without a stethoscope, or you may even hear stridor. Remember, stridor is the soft tissue of the neck swelling. Hoarseness or a muffled voice, or even a loss of the patient's voice, and a change in their respiratory pattern. Likely this will be rapid, noisy, and they will look like they're working hard to breathe. During an allergic reaction, it's common to see the heart rate increase and the blood pressure drop. The patient may also complain of itchy, watery eyes, a headache, a runny nose, or a sense of impending doom, as though they feel they are going to die. Nausea and vomiting may be another symptom or sign that the patient exhibits. This may be a way for the body to get rid of the allergen that it's being exposed to. But as the patient's condition continues to deteriorate, we're likely to see an altered mental status, changes in the skin that are now dry, pale, cool, or clammy, and also changes in our vital signs. With that increased pulse and respiration and a decreased blood pressure, we may begin to see the pulse and respiration start to drop as well if the condition is not corrected. Patients can have reactions again to many different allergens, and these reactions can start off very subtly, but it is important to look for these signs and symptoms, and the patient should acknowledge if they have had reactions in the past. In order to truly be anaphylaxis, though, the patient needs to have either respiratory distress or signs of shock. As with all of our patients, our assessment begins with our primary assessment and evaluating the ABCs. In extreme anaphylaxis, we may have an issue and need to address either the airway, breathing, or circulation. During the secondary assessment, we want to ask questions regarding the patient's history of allergies, what the patient was recently exposed to, how were they exposed to that allergen, what signs and symptoms are they feeling, how has this progressed since the onset of the symptoms, and we want to make sure if the patient has tried any interventions on their own, what they were. Don't forget, a baseline set of vitals is going to be extremely important, and that will be compared to the next set of vitals in order to trend the patient's condition. Think about potential allergens that the patient may have come in contact with, and if they say that they have had a reaction to something in the past, that should raise a red flag. Sometimes the patient will not be aware of an allergen that they have come across, but as we do our assessment, we may see these signs and symptoms of itching, hives, trouble breathing, or those signs of shock. Remember, our airway and breathing can be impacted very quickly when we are dealing with an allergic reaction, so it's important to open and maintain that airway quickly. Use high concentration oxygen if the patient is showing signs of distress or signs of anaphylaxis. If the patient has an altered mental status, be sure that we can maintain the airway. And if the patient is not breathing at all, artificial ventilations are required. As we are assessing our patient, if the patient appears to be having a severe allergic reaction or anaphylaxis, we must determine if an auto-injector of epinephrine is appropriate. An epinephrine auto-injector is also known as an EpiPen, but it does come in a variety of containers from different manufacturers. However, all of them are used essentially the same way. If we are contemplating use of an auto-injector, then we need to determine a couple of things. First, is the patient truly in respiratory distress or showing us signs of shock? If the patient is not wheezing, are they showing us signs of respiratory distress and worsening? Or is the patient complaining of respiratory distress or showing those signs of shock? And if they do not have an auto-injector, we may have one. Once the epinephrine has been administered, there are still several things that need to be done. The time of the administration of the epinephrine should be recorded, and the patient should begin transportation to the hospital via ambulance. It is important to continue to reassess the patient. The epinephrine medication may not be enough. It may need to be repeated, especially if the patient continues to be exposed to the allergen. If the patient meets the criteria for Epi and your service does not carry it, call for ALS Intercept immediately. Hopefully, after administration of your epinephrine, you will see the patient's vital signs begin to improve and the patient's breathing become easier. But again, reassess to verify how the patient responds to the medication. Epinephrine is a medication that causes the blood vessels to constrict and dilates the bronchioles. This will then increase the blood pressure and open up the airways. Patients who have had previous allergic reactions, especially severe, are prescribed EpiPens or Epi auto-injectors to carry in their everyday life. These auto-injectors may be carried in their purse or their car or in a child's backpack. They are spring-loaded needles with pre-filled dosages of the epinephrine. They are a one-time use, and they do come in adult or child sizes. In this image, you can see the EpiPen and the EpiPen Junior. The EpiPen is yellow. The EpiPen Junior is green in color. However, keep in mind Different manufacturers may have different labeling or different colors on their auto-injectors. When you look at this image, I want you to note that the blue end on the right is a cap that needs to be removed prior to administration. The orange end on the left is where the needle will be released and the medication will be injected into the patient. Medical control is there for your assistance. If you need to, call medical direction for authorization to administer the epinephrine auto-injector. Some states do allow EMTs to carry the auto-injectors and administer them if it is within their scope of practice and protocol for their agency. The administration of an epi auto-injector is similar to the administration of any other medication. Be sure to verify the expiration date and that the medication is still good. It is important to look at the liquid inside the auto-injector. It should be clear, and there is a small window on each auto-injector for you to be able to see that fluid. Remove the blue cap on the end of the auto-injector and place the orange end firmly against the patient's outer thigh. You're going to be placing this midway between the waist and the knee on the quad muscle. Hold it in place until the entire dose is injected once it has been depressed. It may take a second or two for the entire dose of medication to be injected. Be sure to reassess the patient. You should begin to see improvements in the patient's condition within about 2 minutes. Their pulse will likely increase and be regular, and symptoms overall should decrease. There may be concerns with epinephrine administration to patients with cardiac conditions or those with high blood pressure. So be sure you are contacting medical control if you are uncertain on if the patient should receive this medication. Traditional thinking was that EMTs should only give auto-injectors to patients who have them prescribed to them. However, we know that time is of the essence, and so the sooner the patient is able to receive that epinephrine dose, the better their outcome may be. So many systems are now allowing EMTs to carry and administer epinephrine even in situations where the patient does not have an auto-injector prescribed to them. Be sure you know your local protocols and your scope of practice with your agency. If a patient has never used an auto-injector before, they may be uncomfortable or afraid to use it without your assistance. So assist the patient by looking at the auto-injector, verifying the expiration date and the color of the fluid, and keep reassuring them that this medication should help alleviate some of their symptoms. The injector is long enough and sharp enough to be able to go through the clothing, and the patient does not need to be undressed in order for the auto-injector to work. Again, review your local protocols on if patient-assisted auto-injector administration is permitted. Be sure to reassess the patient, again, approximately 2 minutes after providing the medication. The patient's airway and breathing are going to be extremely important, again, to evaluate for improvement. If the patient continues to deteriorate, you may need to give an additional dose. Most auto-injectors come in a package of 2. This means the patient needs to have that second injector, or we may have to get additional auto-injectors from the ambulance or from another crew. In order to give a second dose, you must get permission from medical control. Due to cost, Some services are no longer carrying the auto-injectors for EMT administration of epinephrine. They now have a vial with a hypodermic needle and syringe to draw up the medication and inject into the patient. Usually only 1 ml of epi is carried in a vial or ampule for injection for anaphylaxis. A second provider must verify the dose that has been drawn up to ensure that the patient is getting the appropriate dose. For adults, 0.3 mLs is administered. This is the same amount found in the epi autoinjector. For children, 0.15 mLs is used, and this is quite small amount, so it's important that you have the appropriate syringe in order to draw this up for it to be measured properly. 0.15 milliliters is the same dose found in the EpiPen Junior. Intramuscular needles and syringes are used when providing these injections. Many EMT services have kind of created a small package with all of the equipment needed to administer epinephrine. This package includes the needles, the syringe, the vial of epinephrine, and a review card providing any additional information that may be needed. The EMTs should be properly trained to use the kit, and they should be able to demonstrate their competency prior to needing to use these skills in the field. The agency is required to maintain the records of training for the services the EMT provides. Again, the EMT is able to administer the epinephrine if they have gone through the training and education with their service. This ready, check, inject method is something that is utilized by some, but not all systems. Ensure that you know your organization's protocols. So here is our chapter review, short and sweet. Remember, allergic reactions are common, but not all allergic reactions are anaphylactic. An anaphylaxis is a life-threatening type of allergic reaction and is relatively rare. Many patients will experience itching when they have been exposed to an allergen. However, there are many other signs and symptoms that may be present. A patient with anaphylaxis is likely to display difficulty breathing or signs of shock. These patients are usually very anxious and have feelings of impending doom. Anaphylaxis is an exaggerated immune response causing vasodilatation of the blood vessels, bronchoconstriction of the bronchioles, leaking capillaries, causing swelling and edema, and thick mucus production. Epinephrine is used to treat patients in anaphylaxis. This needs to be done quickly, but can be life-saving. Remember, anaphylaxis does not occur on the initial exposure or the first time a patient has been exposed to an allergen, but continued exposures may cause the reaction to worsen. Anaphylaxis is severe and needs to be treated immediately. As an EMT, it is important that you use your assessment skills to determine if this is truly an anaphylactic reaction or just an allergic reaction. Epinephrine is useful, and all EMTs should have an understanding of how it works by dilating the blood vessels and opening the bronchioles. As with other medications, administration of epinephrine should only be used when necessary. This is in the event of a true anaphylactic reaction. If in doubt, call medical control. So think about this. What are the indications for an EMT to use an epi auto-injector? Basically, what are the signs and symptoms you would be looking for anaphylaxis? This would include respiratory distress or signs of shock. What are some of the common causes of allergic reactions? Allergic reactions can be caused by many things. Each individual is unique in what they may be allergic to or how they respond to that allergen. But keep in mind, medications, foods, insect stings, plants, even cosmetics or lotion may cause allergic reactions in some. Particular to different body systems, what signs and symptoms would you see with the skin, the respiratory system, or the cardiovascular system? The skin may be flushed or red in appearance. It may be tingly. The patient may have a rash, urticaria, hives. They may feel itchy. As far as the respiratory system goes, the patient may have trouble speaking, or you may hear audible wheezing even without a stethoscope. The patient may have difficulty breathing, moving air in and out. The cardiovascular system may show us symptoms including an increased heart rate, hypotension, and flushed or pale skin, depending on the degree of the anaphylaxis. What if we have a 24-year-old who has eaten a meal that he believes contains shellfish? The patient states he has an allergy to shrimp, he is beginning to sweat, and is feeling nervous. The patient seems to be breathing adequately. You do not hear any wheezing or stridor. The patient's face is a little red. His heart rate is 88. It is strong and regular. Respirations are 24, and his blood pressure is 108/74. The patient's skin is warm and moist. Does this patient meet the criteria to administer epinephrine? No, not at this time. The patient is not having difficulty breathing, and they are not showing us any signs of shock. The patient is at high risk to develop anaphylaxis and should be monitored closely. However, at this time, epinephrine should be withheld and the patient should be transported to the hospital.